The broadcast is now starting. All attendees are in listen-only mode.
Welcome, EMS research enthusiasts, to the March 2018 PCRF Journal Club. The Prehospital Care Research Forum is dedicated to the promotion, education, and dissemination of prehospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine prehospital emergency care. Here with the Prehospital Care Research Forum Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by Dr. Tony Fernandez, Sean Britton, Dr. Bill Toon, and who knows, we may hear from David Page, who is traveling right now. We are also joined by study authors today, Rebecca Cash and Dr. Ash Panchal. The study we'll be reviewing today is entitled Exiting the Emergency Medical Services Profession and Characteristics Associated with Intent to Return to Practice, an important study. This one was published in Prehospital Emergency Care, January, February of this year. Now, as usual, this review is paired with an article written by columnist Dr. Tony Fernandez in EMS World called The Trip Report, Turning Research into Practice. And we encourage listeners to check out this article. You know, I want to put a plug in also for Dr. Fernandez. Not only does he review articles each month, but he also pulls a nugget of research out of this. And this month he talks about the ability to pull from a census-based study. So I thought that that was a great little nugget from this month's article. We'd also like to remind everyone about a deadline that is fast approaching for new abstract submissions, educational and clinical, for both the 2018 National Association of EMS Educators Symposium and the EMS Expo International Scientific Symposium. That deadline is April 30th. 2018. So we will be sure to provide one more last-minute reminder next month before our podcast about this exciting opportunity for EMS researchers. Thank you all for joining us today. So let's begin. And we want to remind listeners that you can use the chat feature on your screen. Should be down in the bottom right, and you can type in your questions and comments, and we'll bring those into the conversation as we go. So a little bit of background about this month's article. According to the Bureau of Labor Statistics, the workforce demand for the EMS field is projected to increase by 24% through the year 2024. We know that survey research shows in both urban and rural communities that EMS is inadequately staffed, and one survey that the authors cite, half staffed, and show increases in employee separations. So some information from other health fields and in EMS research, in particular some research from Blau and Chapman and others in 2011, really points to things like dissatisfaction with pay and benefits, stress and burnout, lack of job challenges as reasons for leaving EMS. But we really don't know a whole lot about those who have already left the profession and their intentions to return. What we do know comes from smaller scale studies. So these researchers wanted to take a look on a national scale and first describe the proportion of exiters and the intent to return to the EMS profession, and then second, compare certain features of those who are likely to return with those who are unlikely to return, things like demographics and employer agencies. And then finally, examine key factors that might contribute to the decision to leave EMS. So now I'm going to turn it over to Bill Toon, who's going to describe the methodology. We'll follow with Tony with the results and conclusion. Then we'll bring in our authors. So Bill, why don't you take it away with the methodology of this study?
Oh, is it really my turn?
Okay. It is your turn, you retiree.
Semi. I still ride the bus. So.
That's right. Last month you were actually on the ambulance, so.
That's right. So I only once a week doesn't really mean much. So, okay. So let's go ahead and dive in a little bit to the population, the study design, and the setting. So again, I always encourage all the listeners to please make sure that you go out and you get the actual study and read it yourself. It will make it a more enriching experience for you in the future and as you discuss this. So this is a specific exit component of a large census survey of the nationally certified EMS professionals. It's from October 2013, when the survey was distributed, the questionnaire was distributed, and it was sent to a list of national registered EMTs database as part of an ongoing census survey of EMS professionals. And we'll talk a little bit about that. That's called LEADS. And then in addition is at the time of this study, there was approximately 310 EMS professionals that were in the national EMS certification. Remember, the population is estimated to be somewhere in the US at about 850,000 total EMS professionals, but I think that study is from 2010 or so, or about that time. And that was a look that was done of overall the national picture of EMS. And someone I'm sure will correct me. So what they did is they took the certification of about 95% of the people who had a valid email address listed in the database. The questionnaire was comprised of validated items from the LEADS, which is the Longitudinal EMT Attributes and Demographics Study. And they're actually, this is the second phase of LEADS. So there's LEADS 1, which was roughly the first 10 years, and LEADS 2 is the second 10 years, and hopefully there will be a LEADS 3 that will come out of all of this. And some people that may even be listening have participated in the LEADS project for over all these years. So the questions regarding the factors related to leaving EMS were developed based upon past exit surveys, which has been part of the LEADS database previously in the past. So what I liked is they sent the typical follow-up reminders at 7 and 14 days following the original email that went out to try to get people to respond to the overall participation. And the completion of the survey had no bearing on an individual certification. So this was purely voluntary that they participated in this, and it was approved by the American Institute for Research Institute Review Board, IRB. So it had the necessary approvals. Excuse me. So they were asked to report the number of organizations. So here's some measurement things that came out of this thing that they, and it's interesting. I wonder how many other professions have to do this. They said 0, 1, or 2 or more. And I'm always interested because I always hear at least EMS professionals that have to work 2 or more jobs for this profession. The exit component respondents were asked to indicate their likelihood of returning to EMS, probably return to EMS, those who do not intend to return or probably will not versus definitely not. And so there was this scale that was used, and then they had to rate the importance of this. They were asked to answer items related to prior employment characteristics, their certification level, if they're what level EMT or EMR, EMT, intermediate, advanced EMT, or paramedic, how long they were in, 2 years or less, 3 to 10 years, 11 to 15, and then the type of agency that they worked for, hospital, fire department, military, government, on fire, private, and then response were just response with 911 response with transport capabilities or without transport capabilities, and then all the subspecialties of helicopter and everything. And then they were asked to be able to put in their months of work, 0 to 2, the months not working for EMS, 0 to 2, 3 to 5, 6 to 12, and then more than 12 months, and then basic life support, advanced life support. You can imagine they gave every kind of descriptive that they could use to identify the population without identifying any specific individual. So nothing in there was identified by an individual. And there's a chart up here that's displayed on the screen right now that talks about the different demographics and how it's balanced out between male, female, ethnicity, certification level. All the information that I just talked about is clearly brought out in that.
Yeah, and Bill, I think it's important too for those out there who are maybe just learning research to understand that when we do break down demographics and employment characteristics like this, when you see all of these things, it's not arbitrary. It's something that you think might be associated with the outcome. You're trying to anticipate, what kind of things might affect a person's ability to, or what kind of things do we want to look at that might be interesting, right? I mean, just sort of come up and say, yeah, let's just describe by age and race and gender and these things arbitrarily.
I agree, and I think the other richness behind this that if you're not familiar with the LEADS studies and their previously published papers or anything like that, you can go to the National Registry of EMT's website under research and look and see the actual previous studies that were done and the information that came out of it. It's really a wonderful study that really helps dig into our profession. So just real quick with results here, and then I'm going to turn it over, just the number wise of the results, and then we'll talk about jumping it over to the outcomes and everything. But they had 32,000, a little over 32,000 respond to the full electronic questionnaire invitation, which is a response rate of about 10.4%, which is a very respectable response rate. There were a little over 1,200 respondents who indicated they had left the profession and were not currently working in EMS. A greater proportion of the exit respondents were male than female. And then again, if you look at the chart there in front of you, it gives this exact breakdown that I'm talking about here, and it takes you all the way through what the kind of respondents, how they answered their specific questions, so you have a good breakdown of the demographics and everything. And I think, is it Tony that's going to take over now and discuss?
Yeah.
Yeah, hi, great, thanks, Bill. So I think we got through some of the demographics of who left. So let's talk about some of the real interesting things that they found. Again, great job to the authors on this paper. So we talked about one thing that was really interesting about the desires to leave. We talked about demographics of who left and this sort of thing. But there were a lot of factors that weighed into the decision to leave. There were 4 reasons that were reported by most of the respondents. So the desire for pay and benefits, better pay and benefits, was reported most often. It was at about 65%. This was followed by the decision to pursue future education or further education. That was about 50%. There was dissatisfaction with the organization's management, was about 55%, and the desire for a career change was about 54%. So those are some pretty interesting reasons for leaving, and I think some of them kind of passed the Smith test, so to speak. So there are some other interesting things that they went through for those who actually did leave. It looks like from their results, minorities, there was an association with race, in that minorities indicated that they were more likely to return to the field when compared to non-minorities. That was about 80.5% to about 70%. And there was no difference in gender, and however, there was a difference there was no difference in gender. There was a difference, though, in the longer the individual was away from the field, the less likely they were to return. And also the type of agency the individual worked for and the service type was not statistically significant. So there's some of the things that I think a lot of this, what's great about research like this is a lot of times it'll confirm things that we think we know, but we need some evidence to back it up. And I think this paper does a great job of one, finding things that we certainly may not have known, but backing up things that we also thought we knew. There are some other interesting things that they said that they found, which was the percentage of females that left the field was actually higher than the overall population of nationally certified EMS professionals, which is curious. They represent about 40% of those who left. However, they're about 27% of all nationally registered folks in the NREMC database. It was similar with minorities, which is interesting because, as we said earlier, minorities are more likely to return, but minorities, about 19% left the field, and they represent about 11% of the national registered EMS professionals. So that was pretty interesting. There's a lot of things that I'd really like to get the authors to chime in on their results when we get to the discussion section, because they found that there was an inverse relationship between experience and the likelihood of returning to the field. And some of this may be accounted for in retirement, as they correctly state in their paper, but I think that that's certainly worth discussing. And there was one other thing that I wanted to mention before we go through to the results. One thing to mention about the results in general is that we may have a bit of an overestimation of some of these folks' desire to return, only because these are folks who have left the field but still maintain an address and check emails from the National Registry of EMTs, right? So they surely are certainly have some attachment to the field still, or they'd probably ignore National Registry emails, as some folks probably do who love it in the field and never intend to leave. So that's something that's probably worth discussing. But all in all, this was a really interesting paper, and the authors concluded that this was a cross-sectional survey, and approximately 4% of nationally certified EMS professionals left the field, but the majority did intend to return. So I think one of the things we want to think about with this paper is not only how do we get them to leave, but maybe how do we get folks to return a little bit quicker.
That's great. Thanks, Tony. Let's bring in the authors, but can we start with the methods? A couple of questions about the methods first, and then we'll bring in some of the issues that Tony raised. So we want to welcome the authors first, Rebecca Cash and Dr. Ash Panchal. So welcome, and thanks so much for coming on to the podcast here.
Thanks so much for having us.
Thank you.
Yeah, this is great. Just a couple of questions about the methods first. When we see that there's a 10-point-something% return, what was it you were hoping for in terms of percentage, or is it enough to say, well, as long as it's representative of the general EMS population? At what point, when you were sending them out, what were you hoping for?
That's a great question. So we always hope for the highest response rate we can get, but we have come to find that about an 8 to 12% response rate is pretty normal in EMS. So it's not to say that we like 10%, but we expected around there. And so the issue with such a low response rate is that when we're trying to describe something in a population, when we have a large proportion that are not responding, that are the non-respondents, we need to be certain that they're not different than the people who did respond. So if there are differences between the non-respondents and the respondents, then we might be over or underestimating something about the population. So we do a lot of things to try to improve the response rate, including multiple survey invitations, and we do a non-respondent survey typically to assess for those differences between the respondents and non-respondents. But we do have to also think about how we can frame the answer we have when we only have about 10% of the population.
Okay, that makes sense. So, and do you feel that your population was representative of the general EMS population in particular? I think we had a little bit of a disparity in terms of male to female at one point.
Sure. So we typically check against the census of our the nationally certified population, because that's the only comparison we can really make. And so we'll check that the demographics in terms of gender and the race, ethnicity, and all of that are similar between the sample that we have and the general population. And in this case, there were some differences, especially in terms of females. So we do check to make sure that those are mostly equivalent.
Okay, thank you.
Hey, Megan.
Yeah.
Could the authors, I think it would be beneficial for the audience if the authors just introduce themselves briefly and what their background is.
Sure.
Good idea.
So my name is Rebecca Cash. I am an EMS research fellow here at the National Registry of EMTs, and I'm a second-year doctoral student at The Ohio State University studying epidemiology. So I've been here at the National Registry for about 2 years. We do research full-time, and then we also are graduate students. So this was one of the first studies that I was involved in, and That's me. And then Dr. Panchal over here is our research director.
So I'm Ashish Panchal. I live a couple of different lives. I am an emergency physician by trade at The Ohio State University, and I'm an EMS physician also as being a medical director for a number of agencies. About 2 years ago, I joined the National Registry as their research and fellowship director. And so about half my time is involved specifically in that, as well as my other pre-hospital duties.
Great, thank you. And Bill, did you have a question about the methods too?
Well, I think it's I think I would like them to describe a little bit about what LEADS is and how that relates to this survey. And a question, was this a snapshot part of LEADS at one point, or was it totally a separate initiated study?
This was totally separate. So beyond LEADS, where we were following that cohort of EMS professionals through their career, we were also doing these census surveys of the whole EMS profession in our database. And so that was where this study came from. It was a census survey in 2013, and then for the respondents who had said that they were no longer working was where this sample came from.
Yeah, the challenge with LEADS when it came to looking at exit, and this is one of the reasons that we didn't go down that pathway, is that your N becomes a little too small, right? So even your population that you're following over time with LEADS is a good sized population, and it helps to describe the demographics longitudinally of EMS. But when you're trying to look at exit, and that's like a small population of people leaving, that you'd only have like very small ends to really kind of describe that. So we went the new census route, hoping to get a better idea and a better concept of what's out there.
And the concept of trying to find people who have left. So that's really hard because those people are no longer in our profession, which is why the census survey was useful. So by sending it to everyone who had existed in our database, they were prior certified, we could capture the people who are no longer in the profession that may have not been able to respond otherwise.
We're very big on tag teaming, so I'm going to say one more comment and I'll pass back to you guys. You can imagine trying to catch people who are exiting is really hard. A lot of times people who leave our field have no intention of giving us any feedback to the field itself. And so I love the fact that Tony brought up the concept that so many people are interested in coming back, because it begs the question, are these people the ones who are more interested in coming back? And it does, if these people are the ones who are more interested in coming back, it still gives you good information that these are the people we can keep, that we should probably try to keep. And it also kind of gives us an idea and hopefully a little bit of fear that there's a population of individuals out there that we're not capturing well. And so, yes, with that being said, I'll pass it back to you guys.
Yeah,
and
I wonder.
Megan, I have just one more.
Yeah, go ahead.
So I think it would also be valuable if you could tell, and I remember this was an early LEADS thing because someone may question it, how does the National Registry database and general census database compared to what would be the general population? Because if I remember correctly, there was a survey done to compare states who were not nationally registered versus nationally registered. And if I remember correctly, it showed that there really wasn't a big difference in the makeup. So using your census is a good representation of the generalization to the population.
Yeah, that's definitely true. So there's been a couple of studies where that's been looked at, and they've looked at the concept of what nationally registered appears versus the whole general population. Obviously, we do not have right now any type of data set or anything like that with every EMS provider in the country on it. So this is the best approximation that we have. But when we look at the population in comparison, it's relatively reasonable in that sense.
So for sampling for surveys, we would love to have an enumerated list of every person that we consider in the EMS profession. So enumerated meaning we actually can list out every specific person and then draw from that in a probability sample. So that would give us the best way to draw inferences about the population as a whole. Now, we don't have that, because even at a state level, it's not necessarily easy to find everyone who's in the profession. So the National Registry's database is one way to be able to draw a probability sample or in our case, a census sample where we send the survey invitation to everyone, so that we can then start talking about generalized to the population, in this case, the nationally certified population, but it is our proxy to talk about EMS as a whole.
We have a few questions that are coming in, and a couple relate to methods. Creighton, I'll get to yours in just a second, because that's actually one on recommendations. It's sort of a larger scale question, but we have a question from Chris O'Connor, very interesting. I was wondering if there was any comparison made between EMS providers who were trade union members and those who were not. We had agencies, but do you have anything about whether they were trade union members?
That's a really great point and a really good question. It is not something that we typically collect or ask about. So no, that was not part of that study, but it would be a very interesting question.
Thank you for that.
Yeah, it is an interesting one, especially since the top reason was desire for better pay and benefits. Also, have you done any research to compare, and this is just from a student, nobody identified in particular, but thank you for your question. Done any research to compare EMS pay and benefits with other allied health career fields with similar training requirements, and also other rates of intent to leave in other allied health career fields?
So that's great. That's an awesome question, because this is something that, so I'm a member of the EMS Scope of Practice Model Committee for the revision for 2018. And this is one of those things that we've been struggling with, because obviously there's a lot of variability in our training at all different levels. And so especially education and things like that. And so this becomes very important. When we think about other allied health careers, there are some significant disparities, but they're not consistent. So some areas will be more, some areas will be less. One of the more laughable comparisons that we've found was that medical illustrators actually are required to have higher degree levels and actually required to have more training than our general population of EMS providers. And so there's certain disparities like that, which make it very kind of interesting to see how our field has been developing. But of course, we have to keep in mind when we think of our field is the fact that unlike some other allied health fields, we have no choice but to staff and make sure that people are getting care. And that becomes a big priority for us. So it is one of those dichotomies that exist in the way EMS has developed.
Yeah, I have to point out too, in that graph that you have about the percentage of respondents reporting each factor was important. Two of them are on feedback: lack of feedback about own performance, lack of feedback about patient outcomes. And we have had several discussions on our previous podcasts that this comes up frequently, that the lack of feedback about not only your performance, but about patient outcomes. And I think those are related. And I find it very interesting that those were highlighted as decisions to exit or reasons for exiting the field. So it's that serious. We also have a question, and this is one from Creighton. This is somebody from the this is a technical expert panel member on the 2050 agenda. What recommendations would you offer for the vision for EMS based on the top 3 reasons for leaving the profession, as well as least common reason being from retirement, especially when you think about imbalances in minorities and genders in your results?
I love this question because it is actually opening up the can of worms that we all recognize is out there, that we need to think about what we're doing and how we're doing it for the future of EMS. So I think the first part of this question, when we think about the 2050 vision, retention of our workforce is very important, and we need to think about how we do that. But we also need to think about how we define our workforce and what the workforce really is. To be frank about this, we can't even define where all the volunteers are in our country and what a volunteer's job career could look like. So when it comes to understanding what our workforce is, we are way behind in understanding that. So when it comes to the vision of 2050, I would definitely say that one of them has to be defining our workforce and understanding the workforce's needs first before we understand more about how we can intervene on that. The second comment I would have on that concept is when we think about the concept of better pay, benefits, and things like that, again, this has to be in the context of what we're seeing and what these providers are doing in these spaces, because clearly that's going to tie to not only our education, it's going to tie to all these different pieces. And of course, sadly, in EMS, we have lots of competing interests. And so as the vision of 2050 comes into play, a big description of understanding those competing interests and getting all the people to work together to try to define and build up our profession becomes very important. The last comment on this question, awesome question, I love the parts. The third part would be the retirement piece. So I think the retirement piece, when you look at this table, it's a little hard to piece it out. So this is why we did a subgroup analysis. So when we look at specifically at the population of individuals who are leaving EMS and looking at their intention to return, you notice as we got older, they had a lower odds of returning to EMS. Now, so we did a subgroup analysis specifically looking at that oldest population. And so when you look at that oldest population versus the whole full population that you're seeing in the figure, the oldest population had the highest percentage of wanting to retire. And so as you get to that older population, that retirement comes much more into play. So I think that 17% that you see in the overall population is a function of the fact that you're looking at the whole population, not just our older population of individuals who have much more of the need to retire.
Very interesting. And Sean, I think you have a question. Sean Britton.
Thank you. I actually came up with a second while I was sitting here, and I opened it up to the group for discussion. Just two observations I've made. The first being that, as the authors noted within the paper, there was a disproportionately large amount of self-identified minority individuals who have left the field, and also a statistically significant response from them that they look to return to the field. I wonder if that indicates that because they are still committed to the profession, they felt they had to leave the current job environment because of some sort of culture or basically lack of inclusion. Could this be telling that the reason they left was because they felt that they were not welcomed within the workplace, so they still want to be in the field, just not necessarily in the organization which they were in, which is why they currently are outside of it but looking to return? And along those lines, with 55% of the respondents looking to return saying, or actually 55% of the respondents who left saying that management dissatisfaction was a part of that, but we have so many people looking to return, does that indicate that there might be some managers out there performing so poorly that people are choosing to not work, even though they want to work somewhere else, just can't remain with the current management? So I throw that out to the group. Thank you.
So that's a great question. This study was conducted in 2013 through 2014. So the political climate may have been a little bit different then, but you're right that it is possible that the workplace that they were in was perhaps so uncivil that they left that workplace and are looking for another EMS job. And we have done some work looking at incivility in EMS workplaces. And while it is the prevalence of incivility is pretty similar across EMS to other allied healthcare settings and even postal workers, actually, we know that it appears that it's also associated with these workforce reducing factors. So people having higher levels of stress, and that could lead to burnout, also having more workplace absences and that kind of thing. So it is possible that that one specific manager or the culture of that organization led to leaving that workplace, and that they would be open to going to a different one. We unfortunately can't assess that in this study.
To add to that, we are actually in the midst of getting a paper ready for publication looking at 10-year demographic data on our workforce, on initial certification individuals. So specifically people who are initially certifying and what their demographics look like. So what is their sex and what is their minority status? And the scary part is when we look at that data over 10 years, it's pretty much a flat line for EMS. So that gives you a vision. If we think of the fact that most EMS providers' careers span anything from 8 to 15 years, I mean, if that's the vision that we have right now, then we're not changing anytime soon. So that becomes very concerning. It's good to see that some of the minority individuals want to stay in, but if our initial certification isn't changing, we have a defined population and we have a problem or an issue somewhere along the way which is not only affecting people who are staying in the field, but it's also affecting people coming in the field in the very first place. So this could be the managers, as you described, but it even starts before that. So there's something about how we're recruiting for people to come into our field, which is not reflecting the general population of our nation.
Yeah, as expected, we have a lot of questions coming in and some really good ones. I think, Sahej brings it up. I think it's really important, thinking about this return too, this intent to return. Even given this list of things, desire for better pay, I'm leaving because I don't have great pay and benefits and I need to pursue further education. I'm dissatisfied with management, lack of feedback. Still to intend to return. It's almost as interesting a question as why do you want to return? If you have these things that are promoting you to leave. Michael Caducci asks, did you find or look at any correlation between staying in the field and any level of education? Are individuals more likely to leave as they get degrees or more likely to stay?
So to the second question from Michael, so we didn't look at that in this. However, we are working on another study. We are working on the manuscript for it, looking at the most important factor based on certification level. Because we know that pursuing further education is an important factor, but do they come back after they get a degree? We don't know that. And are certain levels more likely to want to get further education? So that, look out for that. That'll be coming, shameless plug for another paper from us. As for the second question, or the first question rather, hold on, let me read it again. So the list of factors. So this is specific to EMS. There's been other work in smaller samples, in convenience samples and in leads and whatnot, looking at this issue where they sort of fine-tuned a list of what are the factors that people seem to be coming up with. So it's not validated per se. It's, I suppose, face valid, as in we know from our experience that a lot of these are the reasons that people leave. But there are also other reasons. And we, even from some other work we've done, we know that things, we think that there's a shortage of jobs, but we also have found anecdotal evidence that there may be actually not enough jobs in some locations. So this is not an exhaustive list at all. And there are definitely other reasons that people would leave the field.
In our future study, what we're doing is we actually gave them a free entry area so that we could actually become a little more exhaustive. Sadly, if any of you have done survey research, it's kind of fun looking at free entry because somewhere along the way, someone is going to refer to poop. Yep. And so that is just the nature of survey research.
Yeah. And so determining these factors, it was just a review of other studies, the list of exit factors that Sahej Khalsa from New Mexico, he asks about that, and I know you were addressing that. But so you said it wasn't a validated list, but how did you sit down and come up with this list?
So it was from prior studies and from expert opinion and what we have known about in the past is where these options came from.
Okay, and then someone brings up, let me see here, this is from Chris O'Connor. Thank you for raising the question. It's all fascinating. It'd be very interesting to do an international comparison. Lots of potential avenues for exploration. And I would agree, the international comparison would get interesting because we'd have to look at levels of providers since we see so many different levels of providers and background and training.
As well as physicians, right? So as we go international, especially if we look at the Paris system, so much of the Paris system has physicians involved so tightly that it actually helps with retention because there's on-the-job training, online, like FaceTime medical direction occurring, which gives it a very different feel. I mean, I definitely think that it'd be very hard for me to leave EMS if I'm putting somebody on ECMO in the Louvre.
Mm-hmm. Oh, no, I just got an image of that. ECMO. That doesn't make you want to go to France. Nothing does. Okay, Tony, you got any questions for our authors? I've been kind of leaving you in the dust here.
I think they did a really good job, and we went over a lot of the questions. I think one of the things that would be valuable for those who are listening, and you mentioned it earlier, is to talk a little bit about why a 10% response rate in the census is not only acceptable but pretty impressive in terms of this survey. And I'd love to get the authors to talk about that a little bit.
So for the census survey, this was sent out to over 300,000 people, actually. So to get a 100% response rate, we'd have probably broken our statistical software. So we ended up with 32 or so thousand people who responded to the overall survey, and then there was, a small proportion that had left and were included in this analysis. So when you do like a sample size calculation, essentially, when you're trying to look for differences between groups, we would essentially only need 1,000 responses. Worst case scenario, when you're looking, if there's essentially no difference between the groups, you need just over 1,000 people. And so to have 32,000 people responded means that we are very well powered to see and detect a difference at the 95% confidence level. So we know that we would see a difference if there was one. The 10% response rate, though, means that we may not be seeing the difference that's reflective of the whole population. For that, we have to assess if there are differences in the response rate by certain characteristics. So the 32,000 responses is a big deal, even though it is a 10% response rate.
I think that's one of the challenges that we have to think about when it comes to EMS in general too, is that there are some questions that we need to ask and we need to get an idea of, and our response rates may not be the most important piece in that, right? So like, let me give you an example. Like if we're thinking in this term that we want to think about and define why people are leaving and stuff like that, we just need to get an idea of what we're facing. Because right now it's even hard to have an idea of what we're facing or what the problem is. So one of the things that one of the other research that we're doing on incivility is it's hard to even define what incivility in a population looks like, and also what kind of settings that incivility would occur in. And so you would need a larger sample to look at that. But again, we recognize that we're going to have small samples, small response rates, like the 10 to 12%. We recognize that that's pretty normal for EMS, but it is enough to bring the issue to the forefront such that we can talk about it, because I think what we're finding, at least in our research so far, is a lot of these kind of things are, is it the chicken, is it the egg, or is it the rooster? How are they all interrelated and how do they work? And we see contributions of each of these affecting our workforce, but we need to start pulling in the data to try to actually get a better idea. Eventually, it'd be great to have a real like a state to look at where you have high response rates in a specific state, such that we could actually piece out what each of these contributes to.
And on response rates in general, so a lot of journals and reviewers will say, well, if you don't have a 75% response rate, I'm not going to look at this. But the reality is 75% response rate for a face-to-face survey, sure, that might be possible. For a mailed survey, you're going to expect a little bit less. And for an electronic questionnaire, we know that the response rates are less. So even a 30% response rate for an electronic questionnaire, which this was, would be considered phenomenal.
Yeah, that's a great point.
I think that's great, and I couldn't agree more. And I appreciate the in-depth explanation of that, because as you said, Rebecca, there's so many places where they focus solely on response rate, and there's a lot more to it than that. So I thank you for diving in there.
Yeah, and it's really daunting also to design a survey. Like you said, you had to develop these criteria and then decide whether to put free text boxes. From Robert Steeps also, he wants to say that he agrees with the comments regarding free text boxes in survey research. That can be daunting. It can be a little scary saying, okay, I'm going to put free text boxes, but now what do I do, with them when people have a chance to freely write? How do I go about evaluating those? And not a lot of people have, maybe experience with qualitative research or with thematic analysis or coding. So, that can be a little daunting. As researchers, how did you decide to handle free text?
So it's a fine line. You develop a question, you think it's the greatest question in the world, you test it, you check that you have all of these mutually exclusive categories and you've covered every angle, and then there's always someone that it doesn't apply to. And so that's where the free text option comes in hand. That allows people to have their input where you maybe missed the boat and didn't think of that angle. So, you have to draw that fine line. Are you testing and looking for specific information that you can do in a closed-ended question where there's just multiple choices? Or do you really need to elicit responses from your respondent that are specific to them, which is a free text box? Knowing that when you get that free text, there's a lot of work that has to go into it. So if you're not going to do something with it, then it may not be worth collecting it. So in our case, we knew that these were factors. For example, in the figure up on your screen, we knew that these were factors that are commonly cited, so we included them, knowing that it wouldn't be everything. But to put a free text box in there and potentially have 32,000 responses to go through was not also going to be feasible or meaningful for us.
And to add to that, I think one of the things that we always have to consider is surveys aren't just making up the questions, right? So much of the survey methodology and survey design is what Rebecca was just talking about, is the fact that you got to test the questions. So one of the things that we always do is cognitive debriefing. So we actually take these questions before we launch or anything, take it to providers of different types and say, hey, what does this really mean to you? And have them answer the questions. And you'd be amazed at how even though we are EMS providers, we miss the boat sometimes. So it's one of those challenging things that even when you're doing surveys and you're just making a survey for your own agency or something small, cognitively debriefing it and getting somebody else to give you some really good feedback of what this really means and what is it saying, it becomes really important, because a lot of times we write surveys which are almost self-fulfilling, right? We write the question, and the question ends up being almost a self-fulfilling prophecy, because we put it together in such a manner. And that becomes one of the biggest things, is you want people to be available to disagree with the answers or choose a different answer without bias and without leading them. And that, I think, is some of the hardest things.
Yeah, like David Page always says, surprises in research are part of it. And sometimes the most fun is when your results are surprising. So can you just mentioned cognitive debriefing. Can you compare that to piloting a survey? So what's the difference between piloting something and cognitive debriefing?
Sure, that's a great question. So with a cognitive debrief, we take a small sample of people from our target population, so EMS professionals, and usually small as in like 10. And we let them take the survey and then guide them through sort of a predefined conversation, I guess, about the question. So it's less about their answers and more about, how did you interpret this question? Were we missing something in it? If we had changed an option to this instead of that, would it changed how you answered your question? So it's really actually getting into the thought process behind the question, so that we know that the construct that we think we're measuring is what we're actually measuring. So if we think we're asking about X and it turns out the respondent thought about Y, then we have valid or invalid data we can't use. So that's cognitive debriefing. And then pilot testing is when you would send it out to a small sample of your actual study sample, usually, or an additional sample, and actually run through to make sure that the survey instrument, the data collection, and all of that is functioning as intended. So we don't usually pilot testing get like one-on-one feedback like you do in a cognitive debrief.
Well, that's great. That's very valuable. And I have a question about the IRB process too. If you're doing a study and you're basing it on census and survey research, and where do you turn to for an IRB if you don't have an immediate area IRB, or now you're a researcher with National Registry, so do you have a standard IRB that you go to?
Yeah, so we actually have a third-party IRB that we use, and if you're at an institution, a lot of them will have an IRB, or you can essentially IRB for hire. You can farm out to an IRB that would review it and give you the necessary approval. And so for any survey research, any research at all, you should do an IRB application, and that just protects you and your respondents and your participants. So we do use an outside IRB to approve our studies.
And so it's interesting when you have IRBs for these studies, because even simple survey studies, it's interesting that about the things that they find which are challenging and which are not challenging. So this survey, obviously, they're like, okay, yeah, people are giving you information about what they feel and they're de-identified. That's okay. We had done a similar survey for a different question looking at seatbelts, and the IRB was all fussy because of the fact that they're like, well, are people going to actually, we can't force people to admit that they're not wearing a seatbelt because that's illegal. And so it's interesting how the conversations occur, and things that you wouldn't think about that should be a problem, that the IRB can have an issue with. And it's really good to use those IRBs, because when all said and done, I never would have thought about that issue with seatbelts, because, hey, a lot of times we don't get tagged with the concept we're not wearing a seatbelt, but the IRB is definitely protecting our public interest by looking at those questions. So it's nice to have that third-party IRB to really evaluate and make sure you're on the straight and narrow.
Great, thank you. Bill's got a question, then we'll return to some of our questions from the audience members. So Bill?
Yeah, just real quickly, and I think you touched on it, but I want to make sure it's clear. There really wasn't a good way to determine people who do this as a avocation versus their vocation, was there?
You mean on a volunteer versus career basis?
Yeah, that type of thing, yes.
No, I don't believe so. In the overall survey, I think we may have assessed about volunteer status, but these respondents would have not received that question. So no, we did not assess if their previous job was as a volunteer or as a career, a paid person.
And the only reason I bring it up is I know that there is a lot of discussion amongst organizations that are predominantly volunteers that they continue to struggle with recruitment and retention. So I was just curious.
That is a good question.
So one of our future work is specifically looking at this whole question of workforce. And so we are specifically trying to geospatially map in some specific states where the volunteers are and look at what the workforce in those areas look like. And so look for that in the future. I think that'll be about a year or 2 years down the road.
That's great. So Hedge actually also brings up if a provider went to work in a non-traditional role, like an ER hospital or doctor's office or whatever, but still maintained EMS, say an ER tech or something, where they counted in the left results.
So if they had responded that, excuse me, if they had responded that they were no longer working for any EMS organization, however they took it, then they would have counted as left. If they considered their role, for example, in an emergency department as still in the EMS realm, then no, they would not have been counted as left.
Now, to add to that, in our future work, when we're looking at this next study about exits, we actually broke down every single field that they're going into and are matching it against the Bureau of Labor Statistics, so we can actually define when people are leaving, where are they leaving for? And so that will tell us a little bit about their education that they're going into and things like that. And I believe Michael had asked something about that. And so that way we can actually kind of try to follow that back. And the cool part about that concept is then we'll be able to also break it down into paramedics and EMTs and really see where people are going.
That's great. And that feeds into the question from Michael McDonald. He says it's interesting that better pay and better educational opportunities are at the top of the list in the age of all the continuing competencies. Is there any opportunity in future surveys to ask what types of further education are being sought? And would that enhance retention in the workforce if the industry provided those opportunities for education? So that kind of feeds right into that.
That's a great point.
And Chris O'Connor brings up a few things as well. He reminds us that there are significant issues related to payment that many friends of his, and I know we see this on site visits going around the country, that you're meeting program directors even. The program director is a full-time job, and it's still working several jobs to barely make ends meet. And what kind of lifestyle is this? It's why he feels it would be interesting to investigate attitudes and opinions, different cultural backgrounds. And one other comment from Chris, looking down the list of reasons for leaving, it appears that many of these issues could be addressed by better leadership, management, and motivation of the staff. Wow. Good points. Yeah, where to begin? It kind of brings up, how do we move also from, how do we balance the kind of validity of a study with when it's time to say, okay, it's time to have a practice change. It sort of gets into Tony's, the title of Tony's article, monthly article in EMS World, which is Turning Research into Practice. So when do we decide, okay, we've had enough research on something to say that we need to do something about it? I'm not really sure of the answer. I'm just bringing it up. I did bring up the whole thing about feedback earlier because that has come up several times, and now a few, buried in other studies. We see this lack of feedback as an issue that EMS providers have identified individually as a serious issue. And what are we going to do about it? So when do we, just if you have any opinions, when do we decide, okay, we've got this study, what else do we need? What more do we need out of this before we can say, we have enough information to say that recommendations out of this are, providing more education or requiring education, or, what kind of things can be brought out of this?
Well, this is Ash. I think we're there. I mean, my perspective, just being an EMS medical director and wearing the hats that I wear, we're seeing the damage that it might be doing to our systems. So we're seeing turnover, and we're seeing a lot of people working multiple jobs and jumping from job to job to job. So clearly, there's a cultural component to what we're doing in the manner in which we've done it for such a long time that we need to address somehow. And when we're looking at how our workforce is changing over decades of time, and seeing that they might be staying stable and stagnant compared to other allied health fields, which are becoming more diverse and being responsive to what our patient population looks like and what their needs are, it does bring into context that we should be thinking about this. And I do think on the higher level discussions, like with our EMS scope of practice, this was a major discussion that we talked about in the model revision when it comes to what we want to do with education. So the discussions are happening. And the thing is, the discussion also has to happen on the state and local level. And we really probably have to, eventually we're going to have to really take a really hard look at ourselves and say, what are we doing and how are we doing it? And I think one of the classic things we can talk about is our dark humor. I mean, that's all part of EMS. We say, hey, that's just being an EMS provider. But is that actually true? Is that taken away from the concept of being a professional? Is that affecting people wanting to come in and work with us and be with us? And so these are all hard questions to answer, but I think we're getting enough feedback out there that and just looking at the data where we're at, it's probably time to really start thinking closely about this.
Great. Bill?
So sort of to tag on to what you're talking about there, and I'm going to maybe put you into a little bit of a pressure question here. Is it not time for the EMS profession to become self-regulated and self-directed, as is happening in the United Kingdom, Australia, and in provinces in Canada? Are we not falling behind by us not truly being in charge of our own profession?
That's a really good question. I think there's a lot of issues to that. Now, just to add to that question, are you meaning in terms of medical direction, or are you meaning in terms of enforcement ourselves?
I think really very much like we should be fully self-regulated by an organization that represents truly probably at a state level that goes to a national level. And on top of that, add into self-direction, an independent practice where we truly become equals healthcare providers, much more like advanced practitioners. And it probably needs to be scalable based upon whether you're working at the emergency medical responder level or working all the way up at the paramedic level, because I think that when you look at people, they say, well, there really isn't much for me to do here. It's very limited.
No, I love what you're saying, because I think there is those situations where there are those low level things. I do. So this is my National Registry hat off and my medical director hat on. I would have to challenge you a little bit in that concept, because I do think that at the same token, a lot of the self-regulated fields have higher education. And so especially if we look at our nurse practitioners in the hospital setting, they're not only getting advanced education, but they're getting internships where they're following, and then they actually have aggressive peer review of their performance such that we maintain the standards of care. So I love what you're saying. I think there's a lot of maturity that we need to do as a culture and as a profession for that to be allowing to happen in a safe and a regulated manner. I think that would be a beautiful direction to go. But I can't see that happening tomorrow, because I think from all the stuff that we've already talked about, there needs to be, we need to learn how to self-regulate ourselves too. And so there'll be I think there's a time and place for that, and it's going to have to develop over time.
Wow. Great discussion. We are just about out of time here. So what a great way to end this great discussion, and thanks to everyone for contributing. I want to ask our panelists if they have any final questions, and then ask our authors if they have any final statements. Sean, Bill, Tony, do you have any final questions or comments?
I just want to say again, congratulations on getting this paper, and the fellowship continues to do great work, and I just want to say keep it up.
I want to thank the authors for contributing to our profession and joining us today, and thank you for the privilege of being a part of the discussion.
Agreed.
Great.
Thank you very much.
Thank you
Great.
guys for having us here and opening this conversation up.
And thank you so much for bringing up all of the tough questions, because I think if we don't start asking those questions now, we're going to look back 10 years and be like, what were we doing? So I love the fact that we're having these conversations at this level, because they'll just push it up. So thank you again.
Yeah, and thank you to our many contributors here, Michael and Robert and Chris and Sahej and all Creighton and all the others who have typed in their great questions. What a topic. Maybe next time we'll have you on, Ash, and we'll talk more about that ECMO at the Louvre. But thank you all for joining us, and please join us next month. If you are interested in presenting an upcoming article for the Prehospital Care Research Forum research podcast, please email David Page at dpage@emsed.net, David Page at dpage@emsed.net. And thank you so much for joining us. See you next month.